if anyone is particularly interested in continuing discussions about some healthcare topics, one of our studio nights tonight is at a agency called Barmer, and they're working particularly in the healthcare space with service design, so it might be something interesting, and I know that there are still tokens available for that. So, all right. Wrong set of cards. Here they are. Okay, so Healthcare 2050. I want to take a second and introduce our panelists. Of course, Mosh and Dewani, you just met. We also have, at the end, we have Siobhan Manning, who is a service innovation and design lead at Mater Hospital. And we have Anna Hellmer, who is a service design and innovation senior lead at Falck AS. So to get started, I want to share with you some statistics that I've been reading up on. First, from a UN article, published UN article on aging, that by 2050, 1 in 6 people worldwide will be over the age of 65, and the number of people aged 80 or older is expected to triple from 143 million in 2019 to 426 million in 2050. A report from the U.S. National Library of Medicine on the pandemics are citing factors such as increased travel and urbanization, climate change, and shortage of healthcare workers for the increase in the future of pandemics. And they are quoted as saying, "The future demands strong collaborations of countries and international organizations in defending against upcoming pandemics." The U.S. Department of Health and Human Services has a report about social determinants of health that you mentioned in your presentation, and how it contributes to wide disparities in healthcare outcomes. People who don't have access to grocery stores, for example, with healthy foods are less likely to have good nutrition. That raises the risk of health conditions like heart disease, diabetes, and obesity. Public health organizations need to partner with sectors like education, transportation, and housing. So my question first is this, and I'm going to start, Alex and Dewani, with you, since you've just spoken on this a little bit. How are you using that kind of radical participatory process that you're engaging in addressing some of these things, sort of looking out at a futures model? And is there one area that you find particularly top of mind amongst people?
I mean, I think in Australia, we had COVID, then we had the bushfires, and it really demonstrated how insufficient and inefficient our health services and structures are. I think in terms of top of mind, I can't think of anything in particular, but we use a lot of kind of futures thinking, like Mosh mentioned before, these kind of postcards from the future or the letters to a future link worker to help people imagine what their ideal version of health systems would look like in the future. Because it's a really hard thing, right? You ask people, what do you want from the future of health? And they're like, I don't know. But, when you get them to kind of think of it in a human way or in, a kind of scenario-based way, it does help them to kind of open up their thinking. And I think the more people you can ask, the more kind of diverse opinions and thoughts that you can get, the more likely you are to get, a diversity-led future that is something that is really appropriate for people.
Siobhan, I know a little bit about the work you're doing at the hospital. Are you engaging in any kind of either participatory design like this or futures thinking to address that? I'm sure at a hospital, right, social determinants of health and the aging population particularly are big factors in what you're dealing with there.
Yeah, absolutely. So and the particular population in our particular demographic actually is one of the oldest and most socially disadvantaged in the country. But yeah, essentially, whenever we're taking on a new challenge, the first thing that we do is go and talk to patients and go and talk to the citizens in the area. It's just become second nature to us. We're very lucky that, so sometimes in health, there are well-intended barriers to talking to people. So you have to go through, the traditional way of doing this was to go through, to do it as a research project. And of course, there's a lot of ethics and stuff like that around research projects. So if you do it as a formal research project, you're encouraged to go through the channel that's really set up to test drugs. So it's the wrong mechanism. And in a lot of institutions, people get blocked from talking to people, which is terrible. But we're just very lucky that our hospital executive sees the value of talking to the people that use the service. So they've supported us in recognizing that this is different to testing a drug. You're just going and talking to people. So we have been able to do that. And it's our first thing that we do is we'll talk to both the patients and their support network, but also to the staff that are trying to deliver the services. So it's just become second nature, yeah.
Anna, how about you? Tell us a little bit about the work that Falck is doing in this arena and kind of what your experience is there with it.
Well, I think similarly to Siobhan, it's been a lot about going out there and kind of interviewing patients and professionals working in the space. And I'm quite inspired to go back now and look at how we can be even more participatory in the way that we bring people in after listening to your talk. It's something that we've discussed previously is like, can we have, a patient panel that we keep going back to or that we use consistently throughout a project? Definitely come up against some of these regulatory or ethics committees where, you have to submit pages and pages and pages of information and it takes months to get approved to be able to test something in the real world. And so, we might, in a more exploratory first phase, try to find people through other channels who have been through something previously who might not be living it right now in the moment because they're difficult to get to, as you said. But through, recruitment agencies, basically, to have them help us find research participants.
That's interesting. There was a question that was posted on Hopin, specifically in relation to your presentation, but I want to open it up to all four of you, all three organizations. How do you go about, in your case, the client, in your case, the hospital, the corporation? How do you get them to see the value there in going out and doing that when it, particularly myself as an American, there's a lot of revenue drivers that are at the bottom of everything everybody asks about, and so how do you manage that?
Do you want me to have a go at that? I mean, we're pretty lucky. Well, I don't think we're lucky at all in Australia to be having these royal commissions. I think we've probably we've just had one released on 222 recommendations for the disability sector. So, I mean, Australia is churning through these reforms. It means government is on edge and listening. So it gives us an opportunity to actually start a lot of these conversations around doing things completely differently. And a lot of the reforms are calling for this significant change. So it does make it easier. But I can say that it is a challenge getting people to trust a process that is so participatory and getting people to, buy in on that. And I think social prescribing is a great example of how we had the client fully just go, I want them to build it, the future, and just go with it. But most clients are like, that is a scary, thing to kind of let go of, and they want to hold the keys. So we're kind of constantly having conversations. We're trying to take them out and get them to experience these parts of the design process to get them to enable, well, I guess ultimately give them a taste for what it can be like, and then build it from there. And we just keep trying to advocate little by little.
Yeah, if I could just add something really quickly, it's two things. It's getting runs on the board really quickly for your clients, like showing some kind of outcome or value really, really quickly, which, sounds counterintuitive to the kind of slow, take time thing I was talking about. So you actually have to carry lots of things at once as a designer in this space. And the other thing is finding your change energy. So there will be people in the room who are frustrated with how things have been for ages, amongst the naysayers and those that don't think the budget is worth it. You find that person and you latch onto them and you use them as your insider. You find that change energy and you get runs on the board quick, and that's a way, but you just have to be so tenacious, You just have to really believe in what you're doing and just don't give up.
Yeah. Anna, Siobhan?
Mm-hmm. I think at Falck, our team is really lucky because we have leadership in the company who really see the value in design and who, built this team. The CEO is really invested and knowledgeable, which really helps. And I think as we began doing these projects, we're a pretty new team. I've been on it for 4 years and kind of started a year before then. People have been using the insights that we come up with, so telling the stories from the research participants and using the data, and I think getting just having the stakeholders internally really use those insights has made them understand how valuable it is, and so we don't really have an issue with convincing them to give us budget for that, which is fantastic. And yeah,
that's great.
Very enviable. It's fantastic. It's so rare, actually, to see that. It's brilliant. For me, my own experience is it's been about a little bit of the little by little, so just building a portfolio of impact. And that just builds the trust, and people start to see that you're not fluff, you're solving problems. And I think if you can frame it in that way, but it takes a lot of time. So even within Ireland, I've had people come and they're like, oh, we'd love to get into design. And then I have to be really honest and say, we're 10 years building this. And that's why we now have 4 designers in the hospital. And they're not even permanent. They're part of the building the next portfolio of success. So it is a slow burn. But people start to pay attention when you're showing them that you're solving problems. The other thing is, if anybody, one particular British medical journal systematic review, it was from 2013. I use it all the time, which basically is really solid evidence that if you pay attention to the service experience in healthcare, it's a critical thing to do. It is not fluff, and there's strong evidence that it is directly related with better patient safety, clinical outcomes, better engagement with the system. And it's a really nice article because it's taken in a journal that's taken very seriously. It's really concrete, hard scientific evidence and it's phrased lovely in the conclusion. It's something along the lines of, we need to stop seeing experience as a sideline thing, but a core part of delivering healthcare.
I want to take just a minute. I forgot to say this at the beginning, so I'll give anybody, my intention here is to be very conversational, so if anybody has a question they want to ask, I'll come over here since you're easier to get to with the mic.
Okay, so thank you very much. Svetlana Penova, I'm actually from public insurance, Burma, so we are having an event tonight, so everybody is welcome to continue the discussion. My question is about experience. It's like a sentence from my heart. So about putting experience in the main center of services. But how do you measure it? So I know there are all these KPIs, like discussions and models and ops going around, but what is your experience? So how you're doing it in terms of hospital or in terms of setting services in public spaces like this one? Thank you.
Will I start off?
Anybody,
thank you for that.
please jump in.
We would tend to use a mixed bag of things because different people like different aspects of measuring. So like there's a national patient experience survey, so we'll often replicate the questions in that because we know they're validated and they've been tested. So we'll do a bit of that, and then we'll do some more qualitative stuff. So we tend to have numbers and human story, but then importantly, in addition to the experience, you have to get onto the impact of that experience. So where you're starting to show, more patients are doing this thing that's good for their health. Fewer people they're staying in hospital for shorter periods, and then you start to get into the organizational benefits of that. So there's sort of a little bit for everybody. That's typically the approach that we take, and we try to have, in healthcare, people understand statistics and they understand statistical validity. So you can't only have, you have to talk to some numbers people, and you have to be able to answer tough questions about how statistically valid it is. But equally, even the statistics people, they respond to the human story as well. So we tend to use that kind of mixed bag.
Yeah, I think it really depends on what topic it is you're working on as well. Like there are different validated scales for things. Like now we're looking into mental health after being a bystander in an emergency. And then there's a scale from Harvard, which is called the impact of events scale, which measures people's psychological symptoms after having gone through a particular event. And then in terms of experience, I kind of like qualitative data when it comes to understanding people's experience of a service, because it's hard to quantify, and I think qualitative data can be just as valuable as long as you get a pretty good sample size. Yeah.
Yeah, I think, just to add to that in qualitative measures, we work with our lived experience participants and partners we ask them, what does success look like to you? What would an ideal service look like to you? How would you measure, a link worker, really successfully helping you with social prescribing? And we kind of call it measuring what matters, and we create these measures that are very qualitative and very human, but making the measures isn't the hard thing. It's actually measuring it, because then you're dealing with systems who's actually going to capture this data? How are they sending it back somewhere? How are we making sure that this data is real? How long is it going to take before we see the change? So you can define measurements really easily, but I don't think we've quite solved how to really effectively capture those measures over time.
Yeah, I mean, it's going to be interesting, with the social prescribing one. So they've actually brought someone in to evaluate the co-design process that we conducted, to then evaluate the success of that and then success of the pilot over the next 3 years. So I think we're going to, hopefully in the next 3 years, we're going to see some of the results of some of those qualitative measures, but actually see how it's played out from the moment of design. And that's going to be quite telling in itself. So it'll be hopefully exciting to see what we find out in that.
That's great. Quick question from online. Siobhan, if you could just, and we'll post this in Hoppen as well, but if you could just share again the name of that journal.
It's the British Medical Journal, and it's 2013. It's all I remember, and I know one of the authors is Cahill, because that's my brother's name. I'm sorry, but it's actually pretty easy to find if you just search patient experience and outcomes. Sorry.
We'll dig into that and get it up on Hoppen. Now, I want you all for a moment to put on your futures thinking hat for just a second, because I want to bring it back to the title of the panel, Healthcare 2050, back to our theme for the conference, Catalyst for Change. As you look out at the future of healthcare and healthcare outcomes and improving those outcomes and improving the range of people who are served through these processes, where do you think that the most opportunity for change is going to come, and what do you think is going to catalyze that? What do you think is going to drive that change, and where do you think it's going to be? Take a minute and think about it, or if somebody has something.
I can have a crack.
Go for it.
Well, I think in Australia what's really interesting is we're seeing a lot of this shift, especially towards consumer-led and lived experience approaches, which has kind of meant that very paternalistic models of care that have existed in the past are being pulled back. There's been such a push around the clinical space for so long, which is all really, really great. But I think what we're starting to see is a shift back some of the other way and embedding that lived experience in some of those models. And I think what we're going to start to see is that more community-centred care, especially in Australia, which we, so often a lot of our health system and where it's fracturing is it's all responsive and all landing on the hospital systems, which just can't cope. We've seen that through COVID. So I think really we're building a peer workforce slowly over time, which is essentially lived experience workers supporting others in the mental health space. So I think you're going to start to see that a lot increase because we just don't have the workforce to support the demand. So we're going to have to think of totally different ways to think about how we support people. And I think one of the other things is it just can't be in central locations. Australia is so diverse. People can't travel for 4 or 5 hours to get support. So how does digital play a really significant role? How do we provide care within the home and in that space? How do we keep people in the environment they feel safe and comfortable? So I think we've got so much work to do, but I think they're just a few of the things that I think we've been thinking about in the work that we're doing.
I totally agree with that. To me, that's exactly where the opportunity is outside the walls of hospitals and the traditional paternalistic institutions. I think it's about looking at healthcare much more holistically, looking at the lived experience of people in their home and somehow supporting well-being starting there. I think hospitals in so many ways are the wrong place to deliver healthcare. And a lot of the work that we're doing now actually is that whole shift left idea and trying to work with people in community and working across silos and departments and organisations, which are basically barriers to looking at healthcare as a lived experience. So I would totally agree. I think that's where the opportunity is, and I also totally agree that that it is the right thing to do because that's where health belongs. But it's also an absolute necessity because the system is crippling. Trying to find, I think the shortage in Europe alone of healthcare workers is going to be 10 million by 2030 or something like this. So it absolutely has to change, and it's the right thing to do.
Yeah, and we've been talking about kind of exactly the same things as well, putting care in different places in the community and also in people's homes. And there's this interesting shift now where people are getting health information from other sources than their classic healthcare providers, where the internet has sailed up to be a really important source, which in a way might be empowering because then you can find different types of information. You're not just getting it from, one source, but on the other hand is also scary because any kind of information can be out there. And then in terms of putting together physical care with mental health care as well and well-being and these aging populations that you talked about, the rise of more chronic conditions in an older population, being able to take care of this from the home, and then not just in the sense of, monitoring something like your blood pressure, but also making sure that you can take full advantage of your life and continue to do the things that you want to do. There's also data, even though there is data on the rise of more chronic conditions in younger and younger populations, there's also studies showing that older people today are physically and mentally stronger than people the same age 20 years ago. So it's not that people are aging and becoming necessarily more sick or incapable, but I think we're not doing the best job of making sure that people can continue to live the kind of life that they want, just sort of stabilizing their condition instead.
Yeah.
Thanks. So I'm curious, you talked about getting insights and bringing qualitative insights into your stakeholders and your clients and bringing those to their visibility. But I think, when we talk about healthcare and obviously the catalyst for change theme that we're talking about here, where I'm from in America, there's a lot of disparity and biases, stereotypes, for instance, in terms of healthcare outcomes for people of color, black people, right? Assumptions about tolerance of pain or mental health, so on and so forth. So how do you manage kind of dismantling those biases and stereotypes that might be informing the work that you're going to build insights for? Because sometimes people will normalize their behavior to the system they live in, and so they might not have the insights of seeing what's happening. So how do you kind of bring other, again, dismantling and surfacing biases in other areas of just, fallacies of thought that you need to break through when trying to make these changes and maybe innovate in these systems and change them?
Do you want to go? You want me to go?
Do you have an answer?
Yeah, kinda.
Me too. Maybe you go and then I can build. Yeah.
Look, I'll give it a crack, but I do really think, what we spoke about around embedding some of that lived experience into the system itself, like trying to transform it from the inside out, where you're starting to create, bringing in that diversity into those design teams itself and into the policy teams, is making sure that we're starting to we're starting to break some of those biases that have been built up by some of these paternalistic models. So I really do think it's like shifting and changing workforces and really pushing really hard around that piece. That's just one of the first thoughts that come to mind. And I think really if we can support that, and that's what we're trying to do in some of our work, is really bring those people that have been vulnerable and marginalised to the fore, and starting with that as the first point. I don't know if you have anything to build on that.
Yeah, I think, we have cultural safety front of mind, and I think even just reading through the Royal Commission, it's just so clear how inequitable the system is. Not just in terms of access, but in terms of how people are treated. And as you say, there's like a standard that people kind of prescribe to that doesn't align with, Australia's very multicultural. We've got people who speak all kinds of languages. And, during COVID, even just getting access to COVID information in your own language was almost impossible. And so there are organisations that are really working to kind of combat this. So it's partnering with them. It's really keeping cultural safety and inequity front of mind. And it's, I guess, when we talked about recruiting and engaging diversity and being really deliberate about the groups that we bring together. Sometimes we just bring together singular cultural groups because we need to really hear and understand more about what services need to do for them and how things need to change for them. So it's being really intentional and really deliberate and being really loud and clear about those insights and challenging the system constantly.
And I think as well as bringing in more diverse designers, also making sure to bring in more diverse healthcare professionals into these services. So in Sweden, where I come from, it's there's different types of groups of immigrants who get worse health outcomes than people who are born from native Swedish parents. And so they're just making sure to have a really diverse workforce who understand their perspectives and their specific health needs.
If everybody's okay with running over by just another minute, I want to get a question from over here. If anybody does anybody on this side of the room have a question, or are these my curious people? You have a question, okay.
Yeah, thank you. My question relates to the topic or the area of prevention, and prevention as an untapped potential of a healthier society. And that's what we all know, what institutions that provide public health, they know it. On the other hand, I'm wondering, do you have any sort of experience, any country that masters prevention from an institutional perspective very well? Have we solved this thing that aligns with also with the personal issue of changing behavior, which is always hard to design for, right? I think that's the core pain or problem. But still, I was wondering, do you have any insight, anything you know about that area where great services are designed so it's easier for people to live a healthy life.
I
and
don't
do
know of
prevention.
any off the top of my head. Probably shouldn't be the first to answer with an I don't know. But I mean, I think it's a very under-tapped area. I think my own sense is that a lot of work that's done in the prevention space is light touch. I don't think it's massive impact. I don't think there's enough that goes into it. I think there's a lot of rhetoric around it, but I don't see massive investment into it. It's also a very difficult area. It's not an easy one. I think when you're working with a really specific population with a particular illness, it's easier to get stuck into it. It's like, where do you start with prevention? It's much messier. So that's my I don't know answer, sorry.
I mean, I'm not really sure how I feel about this yet, but there are new advances in more kind of predictive medicine, which will potentially work as the next phase of prevention, where you can see sort of who is at highest risk of certain things and then make recommendations or put in treatments at an earlier stage to prevent that from like genome sequencing and things. And I think there is potential, but it also seems quite scary in terms of mental health. Like, what do you do with the fact that, you know, maybe you have a heightened risk of getting cancer? What does that do to your mental well-being?
And I think we also have to look outside of healthcare for how we think about prevention. Like, you know, especially around mental health and well-being, like so much of it is, you know, related to housing stability and social determinants. So I think we need to start to look at, you know, maybe we should be solving in some of these other areas, because if we can give people housing, their health and well-being is probably going to be affected in a much better way. So I think it's tricky when you're looking at it internally within that system. You kind of do have to look up and out. But that's probably not a great answer. But there's some things happening in Australia, but I think we have a long way to go in that space, especially in the prevention area.
Yeah, that's exactly what I was going to say. Like, I think prevention in health, as you say, with behaviour change, it's really hard. People don't want to address their own health until there's something wrong. But to Moshe's point, it's about addressing a problem outside of health that's already existing, like housing, like, you know, being low socioeconomic, like, you know, the kind of those other social determinants. So it's looking more holistically. Like, we get lots of projects that ask us, like, to define what a community thinks of health and well-being. And, you know, they have these prescribed answers in their head, and when we ask the community, it's like going for a walk with my friend, or like, you know, being able to afford shoes so my kid can play soccer. Like, it's not medical, it's not clinical. So yeah, we do have to look outside of health to look at prevention answers for health.
Most of the communities we work with, either it's, you know, in their language, things like mental health doesn't exist. People don't know what mental health is. So in Australia, we've built this whole system probably from this Western perspective, and we've completely forgotten about other areas. And that's where I think it's going to be another big shift needs to really start to shift, which probably talks to the point before.
Siobhan, Anna, Dewani, Mosh, thank you so much for your participation and your insights. It's been great. Thank you.
Thank you.
Thanks, everyone.
Thanks.
Thanks, everyone.
Thanks so much, everyone.